Hello, everyone. Oh, hello, Carol again. Thanks for joining us. Okay, let's see. Okay, it's 5 o'clock. Just a little bit of a couple housekeeping items. So welcome to the Friday Q&A right before the exam. You guys must be ready on Saturday. So I wish you the best of luck tomorrow. A couple of housekeeping items. One is that this video is being recorded, and I'll upload this onto YouTube afterwards. So if you missed something, please feel free. You can rewatch it. Also, you can't see this, but I have two boxes here where I have to admit people and where I'm monitoring the chat. So if I'm kind of like bouncing all over the place, that's just me admitting people or trying to answer the chat. I'll just quickly go through the three tips that I usually give with each of these sessions. For the exam, it's really important to keep calm. You would rather answer your questions correctly and run out of time and like miss a couple of questions than go through the exam and answer everything wrong and but finish the exam. So it is really important to keep calm during the exam. As I've mentioned before, if you do feel yourself getting nervous, take 7 deep breaths, as 7 is the target A1C. Now, also another thing is that there are 25 pilot questions on the exam. So that's about, out of 165, that's actually about 1 in 7, 1 in 8. So if you get flustered by a question, if you find a question that, oh, wow, that's really hard, I might go past, you know what, it might be a pilot question. 1 in 8 questions is a pilot question. And even if you spend a lot of time trying to figure it out, and even if you get it right, you get exactly 0 marks. So it's really important that you don't get flustered by a question. It could be a pilot question. Um, Also, the last thing is that I would really suggest not changing your answer after you've decided on answer. Your first gut instinct is usually correct. I talk with people who, don't pass the exam when I process their refund, and I noticed that a lot of them talk about, oh, I went back and I changed all my answers. And that seems to be a trait that a lot of people who don't pass do. So my suggestion to you guys is, don't change your answer. Just go with your first instinct, and I would suggest going with that. Yeah. And with all that out of the way, we've got a smaller group today, which is usual for a Friday, but that means you get more one-on-one time. So feel free to put your questions into the chat or just unmute and ask away. Hopefully someone has some questions. Um, anybody at all?
I sent mine in and you answered them already.
Oh, okay, thank you. I guess that's a good thing. You're well prepared. That's great.
Yeah. I thought the DAPA question is, I have no idea how I'm going to answer that on the exam if it shows up.
Yeah, that's really frustrating. Like, I feel that they should be more responsive to that kind of stuff. But yeah.
Hmm.
Hi, Esmond. It's Josie.
Hey, Josie, how are you?
I guess I'll be better tomorrow at this time.
We all will be.
Yeah, exactly. I guess because I'm just in the hypoglycemia special article, could you maybe review, I guess, hypoglycemia in children? I feel like over the years it has changed a little bit in how much glucagon you give and stuff like that. Like, could you maybe just review that to
Sure,
summarize it? Yeah.
absolutely. Now, I don't work in pediatrics, so I don't have a lot of experience in this area. In the exam form, I've actually asked people who do have experience in pediatrics to talk about it. So there's a couple of changes. One that they've changed this classification system. It used to be mild, moderate, severe. Now it's 1, 2, 3. And then Are you talking about the hypoglycemia update or just the more recent glycemic up glycemic management for type 1 update?
No,
guess
I
it's
guess it's a combination. Like I when I'm studying, I have both the original and the update in front of me.
oh, okay,
And
okay.
then I'm thinking about um
This one right here, right?
yeah, exactly. This
Mhm.
always kind of confuses me.
So I don't have a lot more insight to
Yeah.
give. There are a couple of corner cases where, if it's injectable in glucagon, like what's the dose? They don't mention a dose here.
Yeah,
Um,
so do we just go with, for example, they say intranasal or injectable over 4 years of age. So whatever it is, 3 milligram or 1 milligram, like you don't have to do
mhm,
those small doses that we learned years ago. Like I
mhm.
just remember learning about small doses for mild. Uh, that kind
Yeah.
of confuses me. Yeah.
Um, yeah, like it used to be like 10 micrograms per year of age or something like that.
Mhm.
Um, this would definitely over like any new guideline overrules the old guideline. So, but then it doesn't mention a dose here, which is kind of confusing. So I'm guessing I don't have any experience in pediatrics, but I would assume then you refer to the old guidelines for this. But if they're under, then you would use this. So
So is glucagon even available still? Because we're having a hard time getting it in BC.
yeah, I think they're planning to phase that out actually, because
Yes.
Baqsimi is so much more popular and so much easier to use.
Mhm.
Um, from the Lilly rep I heard, I think they're going to phase out injectable glucagon.
Mhm.
I don't know if it like some generic company might pick it up, but I don't know why they would if the intranasal is so much easier to use. Yeah.
Yeah, and I think I also read somewhere that so under 4, it says specifically that to use injectable, but it does say that you can use intranasal if injectable is not available, which in reality is pretty much the case.
Yeah, like
Yeah. Okay.
I would like why would you want to do that? Like you mix the diluent in and shake it while your kid's like having a hypo. Like, of course I would rather just put whoopsies. Hold on. Okay, got it. I had to admit some people. Yeah, so of course like just putting it up the nose is so much easier.
Yeah, thanks. I just like I guess I remember the stuff I studied years ago. This is my third time writing. So
Mm.
and that kind of stuck in my head because I like the whole trying to calculate based on their weight. And now it's just like injectable glucagon. So,
with no like
yeah.
explanation
So
about the dose. I know, kind of confusing.
okay. Thanks anyway.
Yeah.
Thanks.
Unfortunately, it gets rid of that mini dose glucagon dosing for kids that were refusing to eat,
Mm,
So yeah, I guess there's pros and cons to that.
okay. Yeah, I don't work in pediatrics, so I've never guessed or given that, but yeah. Okay. Penny asks, what are the criteria to test gestational diabetes earlier than 24 to 28 weeks? Oh, that's a good question. I also don't have any pregnancy experience, so
You've never been pregnant, Esmond.
no, I haven't been pregnant lately. So yeah, unfortunately, Dr. Sue Peterson doesn't have any pediatrics or pregnancy experience. So those two areas are kind of like this very kind of like specialized area that we can't really, we're not good at answering those questions.
So I would think that family history and high risk ethnic population, previous GDM,
Hmm.
those kinds of things would be a reason to check before 24 weeks.
Yeah, that sounds very reasonable.
Yeah,
That's what I would go with until I find a more specific answer here, if I
yeah.
can.
I know I just had a girl diagnosed. Well, so she had an A1C of 5.7. So and she's got a strong family history of diabetes.
Mm,
So they assessed her early and they found out that her fasting was in the GDM range.
Okay.
Yeah.
Yeah, I'm not sure if I'm going to be able to find a specific answer. I think it might be up to clinical judgment. Um, yeah, you would kind of, when would testing start? I guess
Like
it'd be,
checking blood sugars 4 times a day, you mean? As soon as you've got an abnormal 2-hour GTT.
yeah, Penny, could you clarify that question? You could come online if you just unmute if you like.
Hello.
Hello, hi Penny, how are you
Yeah.
doing?
Fine, thank you. Just going through that huge chapter. I'm
I
just
know, it's
wondering,
gigantic.
like, yeah, it does give us, that gives us those two different types of ways you check, whether it's with an A1C and or whether it's that 50-gram test, then the 75 and whatever like that. So I'm just curious though, what would make us want to test beforehand? Like it didn't really, I didn't see it anywhere in the criteria, maybe like exactly what Carol said. Yeah, those are the, the flags that make us want to test. But is there actually a time period where it does say a woman who has had previous gestational, so we know she's at risk or whatever? I didn't kind of get that clearly, as in, therefore, we should test at 12 weeks and every 6 weeks, or they didn't give me a number. So I'm just curious if it was really clear, because I couldn't find it clearly.
Yeah, I don't think that it is very clear. I think it just says earlier.
Yeah,
So,
it
so what
just
does
says,
that mean? What does that mean?
yeah, I don't think you have a clear answer on that, unfortunately.
Yeah.
Okay.
Yeah, just earlier, and I think what Carol said, like if they had previous risk factors, maybe you'd screen earlier, but I don't think there's a clear answer here, unfortunately.
Okay.
Yeah, I did hear
Oh,
that this chapter is going to be updated soon, so maybe it'll change in a
good.
new update.
oh geez.
Okay, thanks.
No problem. Okay. Sarah, I couldn't find much information about pass-fail criteria. Is there any way to gauge how well we're doing on the exam? My colleague wrote the exam yesterday and he genuinely has no idea if he'll pass or not.
What
So
was that? Repeat the
my
statement.
my colleague wrote the exam yesterday and said he genuinely has no idea if he'll pass or not.
Oh,
That
yeah.
makes me feel nervous. So unfortunately, they don't the CDECB does not give a mark. You either get a pass or fail. It's based on this kind of strange formula that they use. I can show it to you guys right here. Where's that formula? Here, page 13. Yeah, so a grade will not be given. And they have this formula, which doesn't make sense to me. Where is it? Page 13. Here. So they developed these questions and they used a modified Agnoff method, which I don't understand. And yeah, so you only know if you'll get a pass or fail. Typically, they'll tell you in July. And, you know, there's no, the exam's tomorrow. There's no, if you're nervous, that's normal. Just try to take 7 deep breaths, try to keep calm, and that's really all you can do at this point. So hopefully that answers your question, Sarah. Okay. IG. Sorry, I missed the glucagon injection in pediatrics during hypos. Has the criteria changed from 5 years old and 4-year-olds for injecting? Yeah, so we were just talking about that. Basically, the dose isn't as clear as it was before. It used to be, you use that 10 units per 10 micrograms per kilogram for year of age or something like that. It has changed, and I would just go with what they said in this table here. I know it doesn't give a dose, but when IG, we were talking about like how most people are using Baqsimi now and how glucagon might not even be around. Like I believe Eli Lilly is phasing out their injections and just switching to Baqsimi. Yeah, so I hope that answers your question, IG. Oh,
So,
yeah.
so Esmond, is Baqsimi still needing a prescription for it?
I believe so, which kind of is silly. Well, actually, let me see.
Yeah.
No, we don't ask for a prescription for Baqsimi.
Okay, just want to
And-
make sure.
And what province is that?
Oh, Ontario.
Oh, Ontario.
Okay, you should be able. Then you should be able to
Yeah.
download it. Then let me just check which schedule it is. Okay, I'll double check, but actually you're right. I don't think it requires a prescription, just kind of like how glucagon didn't require a prescription.
Yeah, we check. You can check NAPRA maybe, but if you
Yeah,
type
that's a
in
better idea.
Yeah.
Okay,
but
yeah, I don't think you need a
I mean, if we do, I'm in big trouble.
Okay. And then, okay, I'll just answer IG's questions. I see Julian has their hand up, and I'll get to you right away. How old to use nasal glucagon? It's just right here. Age, I guess you could use, as long as they're over age 4. If 4 or over, you can use injectable glucagon. But I believe, I think it was Carol mentioned somewhere else that if injectable is not available, you would still use nasal because it's easier to use. So yeah. Okay. Okay, Juliana and Glyph, did you have a question?
Yeah, I just have a question. Don't mean to waste anybody's time, but like
we're all
for
here.
the yeah, sorry, when I got in, you guys were talking about pregnancy stuff, which I may have missed.
Mhm.
So the A1C, like the preconception A1C, does that differ for gestational diabetes or pre-pregnancy type 2 diabetes patients? Is it 7.0, but if attainable, 6.5 for both situations?
I believe so. Let me double check, but I believe that so. Ba-bum-ba-bum. Yeah, we were just talking about how the pregnancy chapter is humongous, and it might get it might get an update.
And it might get bigger.
It might get bigger.
is. At first, I had a hard time like grasping the information, and then I later on kind of like put 2 columns side by side of what
Preferred and
pre-pregnancy,
alternate, yeah.
and then gestational, because they differ in some ways, but and like for example, like the postpartum A1C check, it's 775 grams OGTT for the 6 to 8 weeks, right? It used to be 6 to 12 weeks postpartum. Now it's 6 to 8. No, am I saying it correctly? Yeah, something like that.
Let's see. Okay, so oopsies. Yeah, so here's the blood sugar targets. Do I have this on my cheat sheet? Oh, maybe. I'll double check that in a second too. And then, yeah, so these would be the targets here.
The target's for 6.5 during pregnancy. However, for pre-pregnancy, because so there's the less than or equal to 6.1 if possible.
Mhm.
But I think, where did I see that one? 7.0 during pregnancy, but 6.5% if possible.
I think that's for type 1.
That's for type 1 diabetes.
I think so.
Right. So a little bit higher for them.
I think so. Better double check on that, but I think that's what I remember.
Okay, I'm gonna pull it
I
up.
believe that's for pre-pregnancy, before you get pregnant. You're
Yes.
trying to get down to 6.5 if it's safe.
Yes.
Oh,
Otherwise,
okay.
your target's normal 7. And then once you're pregnant, your target goes down to 6.5, but 6.1 if you can do that safely.
Gotcha. Okay, perfect. Thank you so much for clarifying that.
No problem.
Good, good. Okay,
And,
we have.
and sorry if I may add to that.
Mhm.
So functionally independent adults, like is there a particular age for it? Is it like 65 and above?
Yes, so that refers to, well, that's a good question. But it refers to like adults. Like it's not like another person was asking if that does my toddler count, and like no, it refers to like like more older people, let's say. But no, there's no like age for it. If someone had like a heart attack at a stroke at 40 and they're kind of wheelchair bound, and that would be functional, lessening in function regardless of age.
Okay, perfect. Thank you so much.
No problem. Okay, preconception. Okay, good, perfect. All right. Any other questions, concerns?
I have a question,
Yeah.
if I may. For the pregnant, again, coming back to the same topic. So let's say a woman is already kind of taking metformin before she gets pregnant.
Mhm.
So would she be advised by the doctor, like immediately when she finds out she's pregnant, to stop taking it, or does she need to see the doctor and then?
Sorry, go ahead.
Yeah, so that was my question actually with regards to the medications and then
Okay.
getting off the medication and coming back on.
Yeah. That's kind of up to the doctor. I have heard, like, again, I don't have any pregnancy experience, but I have heard people staying on metformin throughout their pregnancy. Um, tip the medication of choice is insulin. Um, like I had a patient who was trying to get pregnant. She was on she was on Ozempic, metformin, and like SGLT2, and then they took all of that and put her on insulin, I believe. They may have kept her metformin, and then afterwards they changed. Once you postpartum, most medications aren't okay with breastfeeding, but people are encouraged to breastfeed. Let's see here, where's that? But once they've after breastfeeding, most medications should be okay to restart. Where is that? Okay, give me 1 second. Um, hmm. It's somewhere in the guidelines. There was someone who asked about it in the exam form, and so here, it's right here. This postpartum, yeah, right here. I just missed it. The metformin and a glyburide can be used during breastfeeding. Once and then so because they're safe for breastfeeding. Once breastfeeding is stopped, then most medications can go back on. Yeah, so I hope that answers your question, Natalia.
Yeah, so basically, like during the pregnancy, that would be actually with like is the decision of the doctor and a lot of supervision, like monitoring to kind of say that she would maintain the metformin. So otherwise, like the insulin is the preferred choice, and that's it. Because
Mhm.
I have never seen like a pregnant woman on metformin. Well, so everybody on insulin. So I'm assuming it's not very common. But I don't know.
Yeah, my friend was only slightly in the diabetes range, and so she like she argued with like the nurses and doctors and kept staying on metformin. So that was her choice. But typically insulin is the therapy of choice. Okay. Any other Julian, please go ahead. Julianne, please go ahead. You're still muted if you're trying to talk.
Oh, sorry. So yeah, just going back to like for example, targets. So so we figured out that pre-existing diabetes for pregnancy, the target A1C is 7.0, but if attainable would be less than or equal to 6.5. Let's say both choices were given on the exam. Like, will that be a possibility? And then now pick which one is better, because both are better. It's just that it depends on the patient if 6.5 is preferable or attainable rather.
Mhm. I don't think they would ask in that much detail, or they would say like, quote, if attainable or something like that. That's how I think they would ask it on the exam. But
Okay.
I think it would be unfair to like give you a choice and not give you extra information.
Okay.
And if they do give you that choice, you should complain on the survey.
Right.
Yeah.
Okay. And sorry, you were saying about like the pregnant stuff. Insulin is like the better therapy choice versus metformin and glyburide, even if those two are okay to use during pregnancy, right?
Yes, let me just show it right. It's right here. Um, yeah, should receive individualized insulin regimen. And then it says elsewhere that like metformin or glyburide is okay, but insulin is the medication of choice in pregnancy.
Okay.
However, I'm wondering with the same, like a few days ago, we were discussing GLP-1s and type 1 diabetes. I'm wondering if, like, what the monograph says about the safety of metformin or glyburide for pregnant women.
So I don't think it's actually says in the monograph that it's okay. So that's kind of like another story. So Health Canada, so how product monographs work is that when a drug company first comes out with a drug, they have a patent towards it. And they've spent like say like $1 billion to research the drug. Then they have like 10 years to try to make back that billion before generic companies can start copying it. So during that time, they have money to like update the monograph and stuff like that. Because updating the monograph, you have to go through Health Canada. It's like a $10 million process. It's it's a lot of work, and you have to do all the studies and blah blah blah. So the problem is like metformin and glyburide are generic now. The generic company is not innovating anything. It's just copying a formula, and so they have no incentive to update the monograph. Because okay, let's say a drug is still on patent, and I could say, oh, now you can use it in type 1. Okay, now there's more people that can use that drug, and that could potentially bring in more revenue. However, if I'm a generic company, I'm just a copycat. And so if I spend $10 million to update the product monograph, well, I don't get any benefit out of it because each other generic company is just going to copy me, and I've just spent $10 million for their benefit. So that's a little bit more complicated. But because metformin and glyburide have been around for so long, especially in pregnancy, they are like you don't have to worry about that issue with the monograph. It's kind of like common therapy that you can use these in pregnancy. Does that kind of explain how it is, Natalie? Does that answer your question, Natalia?
Yeah,
Okay.
it does.
Okay.
However, yeah, it's a bit the way the recommendations are worded is a bit confusing. That's why.
The wording is funny. Okay. IG, can you go over some important points of icodec insulin? Okay, so I can mention a couple things. So icodec is the new once weekly insulin. When you're switching over, it's actually quite easy. Like, let's say someone's on 10 units a day, then their dose is 70 units a week, and you just inject that 70 units once a week. Some people suggest doing a 50% loading dose for the first injection just to get the levels to steady state because because it's such a long-acting insulin, it can take a long time to get to steady state. So, so for example, let's say you have that person 10 units a week, 10 units per day. Now there's 70 units. So for the first dose, you give 105 and then 70 thereafter. They did mention a weekly in the update, the chapter 41 type 1 update. They are actually kind of negative about it, actually. They said that it caused twice as many lows as the usual basal bolus, and so kind of poured cold water and didn't recommend it. So
any type 1 that I know doesn't like a weekly.
oh, okay, interesting.
Yeah. I mean, if you've got any kind of a life at all, a weekly is not good for you, right? Like, because I mean, if you're going to go do the weekend warrior thing, you decrease your Basaglar, right? But you can't do that,
Hmm.
right?
Yeah, it's much more, it's difficult to adjust. Yeah, for sure.
Yeah.
Yeah. See, significantly increase the rate of hypoglycemia almost twofold. Therefore, the added benefits outweighed the risks. The risks outweigh the benefit in this case. So yeah. And as Carol mentioned, like it's much less adjustable. You can't adjust it for things. So yeah. Okay. I hope that answers your question, IG. Sharon asked, metformin can be used but crosses the placenta. Yes. Okay. What's this?
Oh, that was like a quiz
Oh,
that was given to me earlier. So, like for Jennifer, 72 years old, like would she be still functionally independent? She's living alone, but like her status sounds like she could be dependent. So then, yeah, how would you approach this question if you don't mind?
sure. So let's see here. So she's history of severe hypoglycemia. So for me, that means we're not going to aim for 6.5. Mild cognitive impairment also means that we don't aim for 6.5. Lives alone. Well, she lives alone, which means she's not totally functionally impaired. So in real life, I would try to change her medication so that she doesn't have so much medications that cause low. But I would guess like the answer would be B or something like that. Is the answer A?
Honestly, I don't know.
Oh, okay.
It was so our clinical pharmacist wrote the CDE 5 years ago, and I find that the quiz that he had prepared for me, there's a little bit of discrepancies with the numbers. So like some of the questions I would have to like per the current update, this is the, we haven't gotten to that one, so I thought I'd ask you. But I
Okay.
mean, it's fair. I think it's the higher A1C target would be preferable given the situations,
Mhm.
on like that question.
Like there's definitely 6.5 definitely 6.5 is not answered. I feel you could argue 7.5 would be reasonable.
So in the where did I see it? The new there's an update. Oh, I think it's in the slides on the elderly, and it's actually a really nice slide there of what the A1C should be with the frailty index. And
Mhm.
frailty index of 1 to 3, it's still 7%. It doesn't
Okay.
go up until frailty index of 4, I think.
Oh, interesting. Okay. I'll have to take a
Yeah.
look at that.
Yeah, I think. Oh, is this the slide?
This is the guide. This is the guidelines, page 286.
But if you go into the slide deck for the elderly, then there's a slide there.
Okay, let me look for that. Slides. Uh,
Yeah, 20. I just reviewed this morning, so I hope my memory is still good. Because I've got some patients and I go, oh, what frailty index are they actually? So I was looking that up.
Taking a long time to load.
Mhm.
So Okay, so like I would say this person is between 3 and 4.
Hmm.
And so if she's 3, then it'd be 7.
Right.
There you go.
Okay, and I think it's like 3/4 of the way through the slide deck. Oh,
Okay, so there's
might be the next one.
Okay. Oh, okay.
Yeah, right, there you go. Oh, and then there's an even a better one, I think, after that.
Okay, give me 1 second to look for that.
Yeah,
Oh,
right
okay.
there, that's beautiful.
Oh,
That tells you exactly what the
okay.
A1C should be.
So, but then it's a little bit because like, is she 4? I would, if she lives
Yeah.
alone, yeah.
And then it becomes clinical judgment whether she's a 3 or a 4.
Yeah, she's one of those two. She's definitely, I don't think she's this, and she's definitely not this, but then it's typically, but then it's like, okay, if she's 3 or 4, that changes the answer.
It does.
If I may add too, like the way I perceive when somebody says they live alone
Mhm.
doesn't necessarily mean they have more independence. It could be
True.
a danger of like if she has hypoglycemia and she's alone, actually I would take that to be like more at risk. So it
Mhm.
even depends how you think of it. Like I thought of it like, oh my gosh, she lives alone and has hypoglycemia, so this is a bad thing. I should go with the 7.5. Like so it
Yes,
really
yes,
depends how you think of it, right?
true.
Yeah, I agree because it says severe hypoglycemia, so meaning that probably there is like changes in her perception, so she may not be able. So for me, the risks of her losing consciousness and falling, like they outweigh the kind of at
Mhm.
her age, they
Yeah.
outweigh the benefits of keeping it below 7.
Mhm.
But also, with so many years of diabetes, she may not feel the symptoms as much anymore, also at her age, plus her cognitive impairment. So that puts her at risk of not being able to identify the symptoms of coming hypo. And even if she's autonomous at home, more or less, still there's nobody there to kind of help her if it happens. So like preventing the risk of hypo comes before. I don't know. I would be 7.5 also.
Yeah, after your explanation, I'm gonna go with that.
It feels like she's too precious to kind of force her.
Hmm. Yeah, and you're right. At 72, there's how much benefit are we getting? Like how many years does she have left? The hypo would probably be more harmful for her in the long term. So yeah, but yeah, that's one where you have to kind of say like, okay, do you think there's a whole bunch of stuff with that one. You have to use some clinical judgment. Okay. Okay, so you had this other question here,
So
Mike.
it's one of those situations where what you do in real life is not what the answer for the exam is.
Yeah, unfortunately, you might run into a couple of the situations.
Uh,
Okay. And then, do you also want us to do question 8 as well, Julian?
No, I think that's okay.
Okay,
The numbers are very helpful.
sure. Okay,
Thank you.
no problem. Okay, any other questions? Oh, how often and by how much do we increase the dose of Icodec? I believe it's 10 units a week. I think that it's kind of like Tracebo where you can't, well, because you only give it once a week, the most you can increase it is like once a week. So yeah, I believe it's 10 units a week. Probably you could probably use the same like 10% or 10 units a week. Okay, any other questions or concerns?
I wanted to know if in the practice tests there were questions about like injection techniques and everything with the reference to the like the fit those
Mhm.
recommendations. Are there going to be questions like that on the exam? How much do they lean towards like actually asking something like that?
So the fit guidelines is in the kind kind of list of references that they put. Let me show you. It's in their resource thing. It's also here in terms of injections. They talk about injection technique, I believe. Let me just see here. Like how many questions there are exactly, I wouldn't know, but it has definitely shown up on my questions, on my exam. Yeah, 1A. Okay, so it's actually quite a big one. 1A,
Ooh,
yeah, 1A being the highest the most competencies. Okay, IG. Says, okay, IG's question is a single daily injection of basal insulin is recommended as the initial regimen when adding to current anti-hyperglycemic therapy as for the 2024 guidelines. However, I thought that one of the test questions, surgeons performing during day and worried about how stated it doesn't matter if start on basal or bolus first. Yeah, so that's a recommendation of the guidelines. So yes, in terms of guidelines, it is recommended to do basal first. However, it's not some sort of law or anything like that. And I think you have to use your clinical judgment when it comes to each patient. So I think one of my questions is where, yeah, there was some reason why he couldn't have lows. And so for him, starting bolus at night would have been acceptable. And so in that case, like in real life, that's what I would do. Yes, the guidelines state that basal is recommended, but it's not law. And I want you to be able to think because you can have a question on the exam where it's like everything is wrong with starting with basal and everything is right in him starting a bolus. But if you just apply the law if you apply the guideline blindly without looking at the situation, then I think you'll get the question wrong. So yeah, I hope that question answers your question, IG. And also, do we start bolus with the biggest meal per day? I thought at the new stepwise study, it didn't matter which meal it started with. You could do either or. I think in real life, it doesn't really matter. Just trying, the most important thing I think for that is that you don't have to start bolus insulin with all 3 meals of the day. That is quite daunting for a patient to all of a sudden have to start taking insulin before each meal. So for the exam, I would, yeah, maybe do like the biggest meal of the day, but in real life, it doesn't really matter. No problem, IG. Okay. Julian, go ahead.
Okay, I was wondering, there's the Saskatchewan travel and insulin dose adjustment file. Do you
Mhm.
have a kind of like a summary for this, kind of like a formula form?
I do so if you look under cheat sheets, right here, I do have I do have an insulin cheat sheet which shows all the different calculations and how to make and how to make a sliding scale if needed.
That okay, I'll review it. Thank you.
Sure. Okay.
Desmond, I believe in one of our previous sessions, someone had a question about traveling and dosing their insulin, and you very quickly showed on your website, oh, it's right here. If you just go, and I missed that. So
No
is it
worries.
possible to
No
show
worries.
me again
Absolutely.
where you found that?
Absolutely. So in after exam review, it's right here. And then it's under, I believe it's under special situations. Let me double check here. Travel. Here, right here. So for special situations, there's just one right here by Dr. Halpern. If you click on it, and then you click on here, it has some examples of adjusting medications for travel and stuff like that.
Perfect. Thank you so
Wow.
much.
And that's in your website.
Yeah, so here, let me show you where it is again.
Okay.
So so after you do your practices, so it's under practice examinations, after
Yeah.
practice exam review,
Yeah.
it's broken up into like pathophysiology, nutrition. This one is under special situations,
Okay, great.
and it's right here, Dr. Halpern. Okay. Well, if there's no further questions, I wish all of you the best of luck tomorrow. Just remember, try to keep calm, don't get flustered by questions, and avoid changing your answer. I'll probably be on the forum for a little bit while longer, but then I'll be off for the rest of the night. So yeah, if you do have anything else, try to quickly get it in there. I'll try to have this posted on YouTube soon. And yeah, I wish the best of luck. And, you know, after this, it's over. So everyone can enjoy their summer then.
Yeah. Thank you.
No problem.
Thank you very much.
No problem. See you later.
Thank
Good luck,
you.
everyone. Good luck, everyone.
Thanks, Esmond.
No problem.